Welcome to the first of many public hearings over the next 2 weeks. And it's my understanding, Jeff, that you would like to open the process with a few words.
Yeah. Good morning. I'm Jeff Tiemann with the Vermont Association of Hospitals and Health Systems, and I want to thank the Green Mountain Care Board and Chair Mullen for the opportunity this morning to address the board. I just have a few minutes of prepared remarks, and I promise I'll be brief. As always, we appreciate your willingness to hear from the Hospital Association as part of this important process for our state and for all Vermonters. As I've said to this board before, hospitals are vital community organizations. They provide care all along the continuum, from perinatal to primary prevention to complex surgery and cancer treatment to hospice and everything in between. Here in Vermont, they do this work extremely well, consistently putting us in the top tier of states when ranked across measures of quality, cost, and access. At the same time, our nonprofit hospitals have demonstrated their ability to help bend the healthcare cost curve. Slowing the rate of growth is another way of saying that hospitals have made great strides in improving the affordability of healthcare for all stakeholders. Just consider that prior to the Green Mountain Care Board, net patient service revenue was growing at an average of nearly 7.7%. By comparison, over the past 5 years, that growth rate has been only 3.6%. This is positive proof that Vermont's hospitals are meeting the goal of managing inflation even as it outpaces revenue growth. The budgets you'll hear about over the next 2 weeks are responsible. They reflect the resources needed to carry out hospital missions, to serve patients safely and effectively, to continue to be steady employers and community contributors, and to invest in health reform and primary prevention. As they have been doing the hard work to root out costs and minimize rate increases, our hospitals are also committed to health reform, which, as you know, entails 2 major components. Payment reform, to align incentives with the ultimate goal, which is the best possible care of every patient, and delivery system reform, to focus more on keeping people healthy than waiting for them to be sick and therefore expensive to treat. With every hospital now participating in our state's all-payer model, nearly every hospital through OneCare, and literally every hospital doing reform work and primary care focus, we are in for the long haul. To stay on the reform path and make the necessary investments and cultural changes, hospitals must be properly supported right now. As some of the current economic indicators illustrate, we have reached a critical point where the financial health of some of our hospitals is now a greater question than it has been in decades or longer. In addition to health reform work and investments, hospitals face a slew of challenges and cost increases, including workforce shortages and salary inflation that put substantial upward pressure on expenses. While it may be tempting to think that we can cut our way out of this, it is not a practical solution to do so. Vermont's hospitals have been working hard to reduce operating expense growth. The workforce challenge alone is daunting, and when coupled with pharmaceutical cost growth and other expenses, can make it nearly impossible for NPSR to cover ongoing expenses. Efforts to push rates below what each hospital is requesting for 2020 can create access problems for Vermonters. At some point, hospitals cannot be squeezed any further, and the result of additional pressure will be to curtail or to eliminate services. For our system, this scenario also involves patients seeking and receiving care outside of our state, which is harmful economically and threatens our all-payer model, which depends on keeping patients in the state and more specifically in their service area. Currently, 6 of Vermont's hospitals are projecting negative operating margins for 19, and 2 have budgeted losses for 2020. Our hospitals will never sacrifice safety or quality, which means they require full funding of their budgets to continue being the vital patient and community resources they are today. As you know very well, we are at a critical point in healthcare, both here in Vermont and across the country. For the first time in decades, maybe ever, in our field, there is bipartisan consensus and now growing agreement among providers themselves that fee-for-service medicine is outdated and will not reduce cost or improve outcomes. Through our all-payer model, we are leading this work in Vermont. Our hospitals were promised transformation funding to fuel their efforts. The vast majority of that money never materialized. And yet hospitals continue to move forward, to lead the way, to make investments, and encourage change. They're investing in healthy food, housing, transportation, and building and strengthening community partnerships. These are the social determinants of health. They're working with Rise Vermont to focus on primary prevention and make it part of their portfolio, with 9 hospitals leading campaigns serving 36 communities across the state. In Vermont, we're pioneers of reform, addressing the social determinants, moving toward value, creating true patient-centered care, and serving as cornerstones of our communities in every part of the state. We have now reached a point where scaling back or significantly altering hospital budgets will affect their long-term viability and will alter our reform trajectory. Instead of hearing about advances in reform and innovative new programs, we will be hearing about hospitals abandoning reform, struggling financially, and possibly even closing. Right now, our delivery system is unbalanced from a resource and expectation standpoint. We are being asked to do more with less in an environment where resources needed to carry out the transformation are outpacing the financial resources needed to do the work. I believe that healthcare reform in Vermont will be successful and maybe even a model for elsewhere. I also know that if we expect sweeping results overnight, or we push too hard on the hospitals we're depending on to fuel and lead the journey will not continue. A lot has changed since last year. We had quite a wake-up call with Springfield Hospital, where they're still trying to move forward following the closure of services, including OB. The result of that is a Springfield Hospital that will look very different than it did before and affects the community there in significant ways. We know similarly that 100 hospitals have closed across the United States in recent years. Our association conducted an assessment of those closures and found that the overwhelming majority occurred in states that chose not to expand Medicaid. This startling trend offers evidence that hospitals cannot easily absorb the very real costs of short-sighted policy choices. The bottom line is this: without adequate cash flow, reasonable reserves, and the financial room needed to invest and transform, hospitals will struggle to meet their missions. Their ability to lead reform will be imperiled, and their role as caregivers, employers, and community contributors will be compromised. Adjustments to these budgets may appear to rein in costs, but would in reality create only an illusion of greater affordability, and unfortunately precipitate other unintended consequences, the costs of which are likely to be borne by patients and families. So on behalf of Vermont's nonprofit hospitals, I urge this board to listen carefully to the budgets you're about to hear and to approve the ones you will evaluate. To put it in terms that have been observed by physicians for centuries, first, do no harm. Thank you again for the opportunity to address this board, and good luck with the process. Thanks.
Thank you, Jeff. So the first hospital today is Rutland Regional, and Claudio and Judy, whenever you are ready, go ahead and take it away. Thanks, Kevin.
Good morning, folks. I'm Claudio Ford, the President and CEO of Rutland Regional Medical Center. With me presenting is Judy Fox, our CFO. And also with us presenting was going to be Jeff McKee, who's the Vice President for Community and Behavioral Health. He's the administrator on call. As you can see from the group we have, probably the only one minding the store here. I think he might be coming in, so he might have had something come up, so he'll be joining us shortly. Also with us today, we have members of our Board of Trustees. We have Joe Krause, who's the Vice Chair of our board, who also chairs our Governance and Development Committees of the board. We have Michelle Nelson, a member of our Finance Committee. We have Court Jones, who's the Chair of our Quality Committee. And we have Bob Hedden, who's a board member for us, and he's also the Chair of the local community health centers of the Rutland region, our local FQHC, which employs most of our primary care physicians in our service area. Along with board members, we also have members of our leadership team. We have Jim Greenow, who's the VP of Corporate Support Services, Betsy Hassan, who's our Chief Nursing Officer, Carol Egan, who just retired as our Chief Nursing Officer and handed the baton to Betsy, but is staying on with us for a year in consulting capacity to work on workforce development issues, in particular nursing workforce issues. Brian Kearns, who's our VP of Human Resources, Jonathan Reynolds, who we just promoted to be our VP of Clinical Services, John Wallace, who's our General Counsel and Chief Compliance Officer, along with several of our directors, Sandy Thomas, Director of Finance, Kim McDonald, Director of Revenue Integrity, Laura Pierce, Senior Director for Information Services, Sue Senecal, our Strategic Financial Analyst, Tracy Moore, our Director of Development, Dean Pierce, who's one of our project managers in the facilities area, and we have a few more folks there since we're 15 minutes away, so it's a pleasure for us, and Jeff McKee just joined us. So, to give you an overview of Rutland Regional, many of you, most of you have been up to the hospital. I think all of you have been to the hospital, so you know us a little bit. We are an independent, not-for-profit community hospital. We're governed by a dedicated volunteer board of trustees. Our service area is about 60,000 patients. We run and staff about 144 inpatient beds that we can flex sometimes as needed. We see about 7,000 inpatient admissions per year, 33,000 emergency department visits. We have about 1,900 employees and about 250 members on our medical staff. So, you know, you would characterize Rutland not just as the second largest hospital in Vermont, but as a full-service community hospital that does basic bread and butter, primary health care, a strong cancer care program, and just your general community hospital services. This organization has been focused very strongly on quality and focused on patient satisfaction, provider satisfaction, employee satisfaction, quality of care, and financial performance. And as you can see from the list of our accolades, we have earned an A rating for several years in a row from the Leapfrog Group. We've been recognized by U.S. News and World Report as one of the best regional hospitals in New England. We've earned several accolades from Health Grades for our outcomes, our quality outcomes for joint replacement, for pulmonary care, and for cardiology. We've been named one of the best places to work in healthcare by the advisory board. We're Joint Commission accredited, and we're really proud that we are a Magnet recognized hospital, one of two in the state, which is really important when we're dealing with workforce issues and trying to recruit and retain nurses in particular. Okay.
You can also take it off the stand.
Okay, all right, thank you. So also with Rutland, we're proud of a history of compliance with Fremont Care budget orders and parameters. We're proud to be advancing healthcare reform in Rutland County. We are leading a community-wide effort to create a unified care management system. Jeff McKee is going to talk to you a little bit more in detail about what that looks like. And we've been leaders not just in our community, but on a statewide basis in mental health and substance abuse services. After Hurricane Irene, Rutland stepped up to the plate and on a statewide basis and provided some inpatient high acuity level 1 psychiatric beds, and we still provide those services to this day. We also, about 6 years ago, when the opioid issue was a significant problem for the Rutland area, opened up a medication-assisted treatment program called Westridge Center. We provide methadone, Suboxone treatment for people suffering from opiate addiction. And we're really proud that every year we have about 400 clients that we've given part of their lives back through that program. And also in Rutland, one of the things that through the leadership of Dr. Todd Gregory, the director of our emergency department, he led an effort to help us and also help other hospitals improve the care of people suffering from psychiatric in acute psychiatric crises while they're in the emergency department waiting definitive treatment. We created a specialized 5-bed unit that we staffed with psychiatric technicians. We created a whole program to enhance their care while awaiting definitive treatment. Just going to talk to you a little bit about the community health needs assessment. One of those hands, whatever.
All right, thank you. So our community health needs assessment in Rutland is a very robust process. We take it very seriously. It is led by our community health team. And this last cycle, we just completed the assessment in 2018. And we had 520 surveys returned across all stakeholder groups. And we also did focus groups in 6 of our towns in the Rutland Health Service areas. And that led us to the 4 priorities. We did not rank these priorities because we went through the process with our various committees. We really had a hard time discerning one as being more important or more outstanding than the other. So we kind of said these are the 4 issues we want to work with without prioritizing any particular one as being the most important. For the first time in many years, substance abuse treatment is not on this list. I just wanted to point that out, that we recognize in Rutland County in our community health needs assessment report certainly reflects a lot of discussion of substance abuse issues. But in terms of new resources or where we need to put our energy as a community, we feel like we've actually done a really great job applying resources and getting resources in place to deal with substance abuse disorder in Rutland County. However, each of these 4 areas has underlying the need to address substance abuse within that. So that's reflected in our community health needs assessment.
John, can I just jump in for a second? I forgot to ask the court reporters where you guys at.
I'm sorry?
I forgot to ask the court reporters where you guys at.
Okay.
Yeah, go back.
Should everyone stand? Will we do it one by one?
Whoever's going to testify for Rutland.
3 of us.
Just the 3 of them.
Do you solemnly swear that the testimony of the penalty of perjury and the testimony of the truth will be the truth and the whole truth and nothing but the truth?
Whatever you said before, that was a lie.
So now we have to be true. So the first area was supporting an aging community with emphasis on supporting people aging healthy at home. We recognize that we're one of the oldest counties and one of the oldest states, and that's an emerging issue for us. Housing is a particular need in Rutland County. We recognize that as a social determinant of health, housing, inadequate housing and homelessness predict a variety of poor health outcomes and overutilization of preventable care utilization. And so it's a major focus, and we have a number of initiatives going on through our Project Vision Health Committee related to housing. Child care and parenting is also recognizing, somewhat related to the opioid epidemic. We have many grandparents and extended family members providing care for children that they haven't anticipated. They have specialized needs. Those children have specialized needs. We also have a number of foster children and other kinds of care relationships that are creating a lot of risk in those kids at schools and in the community, and we need to find better ways to support the parents and the kids in this setting. The last one is mental health, and that remains an issue for us. We still hospitalize more kids from Rutland County per capita than any place else in the state. That's a problem. We have a suicide rate in Rutland County that is higher than most other areas of the state. That is also a concern for us. So those are 2 initiatives that we'd like to develop strategies for through Project Vision and through our community collaborative. Through the mental health in particular, just to give you a sense of what we're doing, we have a community-wide zero suicide initiative that will literally affect every agency, human service agency, and healthcare provider in our community. We're very excited about that. Thank you.
Good morning. Wanted to start with just an overview on the dollars and the financial piece of this presentation, just to give you a sense of what you're about to hear. There are a lot of common themes that we will continue to circle back on. So to begin with, you set a guideline of 3.5% net revenue target. We have met that in this budget. We've done so with a mix of volume and a rate increase of about 2.65%. We'll talk about the mechanics of that rate increase. When you look at our history of annual rate increase and the commercial rate, if you will, over a 5-year trend, which does include 3 times in which we have reduced rates, on average, our rate increase is less than 3%. We've set our budget based on reasonable trends, and that trend is volume. We're seeing really consistency in volume. We're not seeing lots of movement in any payer class, nor any market where people are coming to or leaving our market area. Reimbursement assumptions are set on what we know today through the Medicaid program, as well as the Medicare proposed rules. I will tell you the one exception is the outpatient Medicare proposed rule came to be in July. That has an implication to our budget that we have not included. And that is a movement of hip procedures to an outpatient list, very similar to the knee procedures we talked to you about. That is a $1.3 million reduction in our reimbursement. And so we're going to have to watch that closely and look to see what financial implications we'll have. There still is a major cost shift, and we can talk about that as well. We are assuming continued participation in the OneCare Medicaid risk program. We have approximately 7,800 lives. We were estimating through partnership with OneCare that was a $600,000 risk. Updated, new addendum signed in July based on updated information. Our risk is about $1 million in 2019 and in 2020. Our cost structure, we'll spend a lot of time talking about this. Budget to budget, it goes up about 4%. Projection to budget, we're at 2.2. An enormous amount of hard work from the leadership at the medical center in trying to mitigate those cost increases. We've got a $4 million cost reduction that we'll talk to you about. And you'll hear lots of conversation around pharmaceutical inflation, labor costs, both with our registered nurses as well as our physicians. So the lineup, net patient service revenue, how did we get there? We started at $258 million. When you look at our volume and mix of services, we had about $7.7 million of net revenue. Reimbursement, we had about another $1 million, most of that coming from the Medicare program, most of that coming on the inpatient side. Do have about $270,000 of increased Medicaid. In total, our cost shift is $57 million. And so when you look across our payers and you look at that cost shift, about 50% of that is coming from Medicare and another 50% is coming from Medicaid. Of the Medicaid, 27 million, 12 million is a result of the bed tax program. Psychiatric care, we do have, as Claudio alluded to, a level 1 state psychiatric unit. We have seen increased cost with that program. That is a cost-based reimbursement program. So we do have a bit more reimbursement for that program. And then our rates, 2.65%. Because of our participation in the ACO and the fact that we do not employ primary care physicians, we do have to fund the care management payments, but they don't come back to us. You'll see that as a net revenue reduction of about $725,000. And then bad debt and free care, which will be another conversation we'll have today, $3.2 million. This is not our self-insured. This is our commercial population who are coming to us with a commercial benefit that isn't what it used to be. High deductible plans, high copay plans, an enormous amount of stress on both our bad debt and our free care. In total, that gives us 3.5%. So the rate increase, it is not across the board, but it is consistent by payer in terms of what those gross charges are. We were able to lower high-cost imaging, CT and MR. We used the Act 53 comparative reports, where it was our goal to bring our cost charges in line for those services. All of our pharmaceutical and supply expenses are based on acquisition cost. We take the latest cost of each supply in pharmacy, drug, in late summer, and we apply the markup. Any change in the cost structure or the charge structure for those items is completely and directly related to the acquisition cost of those items. We've restructured some professional fees. These are our fees to see physicians and medical assistants to be consistent across the board. The result is that all other charges go up 4.25%.
Okay, some of the, sorry, I have to look at my iPad here since I can't see through the sun to see this right. Some of the hospital issues in terms of access to appropriate care. Mental health, in spite of all we've done in our emergency department to provide excellent quality of care by building our 5-bed dedicated wing in the ED for people in psychiatric crisis, we still, that has not done anything to reduce the number of hold hours or the number of patients walking into our ED with that need and that need to be maintained there under supervision for an extended period of time. So you'll see our trend is increasing and holding at that high level over the last several years. It's a major concern to us. One of the things that you're probably aware of, having seen our emergency CON request, is that the CMS has changed its guidelines for supervision of patients in the emergency department, requiring essentially for us to have staff available at all times to provide one-to-one supervision for those patients. The hospital is spending in our budget, I believe, just over $1 million just for supervision of psychiatric patients in our emergency department, based on those changes in regulation. It is certainly it is good care. It's hard to argue with that from a quality perspective, but it's certainly an expensive change in their regulations. The other issue that we're facing is the increase in subacute patients on our medical floors. You'll see in the chart there that much of that has to do with lack of an appropriate placement. Most of those patients have some combination of dementia or psychiatric illness or both, with some level of behavioral challenges. So these are patients that need to be monitored closely or pose a risk in their environment to themselves or potentially to others. Another group of folks that represent a significant number of days, subacute days, are patients with addictions who perhaps because of the level of medical illness that they have require daily infusions. That doesn't really require an inpatient bed necessarily, but there's no other facility to treat those patients, and that's an increasing number of folks that we have. We are actively in discussions with our local skilled nursing facilities who have empty beds but don't have the programming to care for these patients, and we're hopeful that we'll be able to move the needle on that a bit, but that's really what it's going to take, or additional resources developed statewide, particularly around geriatric psychiatry and high needs behavioral patients.
One of our other issues that we have in the hospital is access, and in order to have access, we need to have the physician complement to be able to care for patients. At the bottom of the screen, you can see from recent publication, the time to third next available appointment. Two highest areas for us have been neurology and OBGYN, both practices that we employ the physicians at the hospital. We had some success over the summer in addressing that. We successfully recruited an experienced OBGYN who started in July. And we also successfully recruited a second neurologist to our community. Again, another experienced provider, so he also started in July. So we made some headways there. But there's three areas that I'm really concerned about as far as going forward. They go into the subspecialties: urology, gastroenterology, and otolaryngology, or ENT. Those are three practices we've been recruiting for quite some time. Three providers who are nearing their retirement in the community, and three services that we as a community hospital feel, for 60,000 patients that we take care of in our area, feel we need local access to. Urological conditions, GI, and ENT are three critical areas. So we are continuing to look at what we can do, but some of the challenges also, technology comes into play. When you're a community hospital, sometimes, so for example, on urology, most urologists now coming out of training, train on robotic procedures, and expect to have a robot available for when they go into practice. We don't have a surgical robot at Rutland Regional, but it is something that if we're going to continue to provide local access to urology, we might need to make the investment in. Same thing with gastroenterology. A lot of times, gastroenterologists want to do specialized procedures, and that's a challenge in a community hospital. So those are three areas we're focused on intently, and going to be critical to have access, and also to catch issues early so they don't turn into acute health crises, which in the long run become more expensive for the system. The other issue that we have is accepting risk. As Judy said, in our budget, we are planning to go into state and Medicaid risk program under the ACO for the second year. We've elected not to go into Medicare and commercial insured risk for year two for a couple of reasons. One is we don't employ our primary care, as we said. Most of the primary care physicians in our community are organized in a large federally qualified health center. And we're working very closely with them, closer than ever before, on creating a cohesive collaborative care management system. That is the key to our success. In the ACO, it's the key to bringing costs down. Challenges are, because we're two separate organizations, one challenge is we're on disparate information systems. So building those data structures and the care coordination structures is important. And we've only been in the risk program for 1 year under Medicaid, and we feel we need another year to do that. The other thing, and probably the biggest challenge that we face, is the leader who started the Federally Qualified Health Center retired unexpectedly for health reasons over the summer, over the late spring, early summer. And they are doing a nationwide search for his replacement, and it's important for them to have leadership and so forth. Again, the data is really important, and again, new in the ACO, we're still trying to work on our end and on their end of getting access to that data, and more importantly, not just having access to the data, being able to analyze it and get it out to the providers and the clinicians. So if they can use that data to change how they're caring for patients, to modify that, to improve and expand upon what's working well, and to address those areas where cost and quality is where we want it to be. And then the final thing, and Judy can talk to you a little further on that, is building reserves. Our risk goes up to $8 million when we go into all three programs, and finding a way that we make sure that we have some reserves on the books for that. It's somewhat challenging because of the accounting rules, etc.
So another issue we'd like to highlight for you is what we call the erosion of the commercial insurance benefit. We have addressed this as one of the primary needs for the rate increase. And what you're seeing here is a graph through 2015 through 2020 that is our free care and bad debt. You can see we were stabilized in 15 and 16, but have been on a 4-year trend up for bad debt and free care. When we look at that, we look at the drivers. 66% of our bad debt is coming from patients who have a primary insurance on their account. They have a high deductible or copay. 46% of our free care is provided to patients who have insurance, and this is the balance after. When you look at the detail, 25% of that is coming from commercial payers, and about 21% is coming from Medicare. We have not changed our free care policy throughout the time frame of this metric, this graph. We will work with our patients, and it is our stance to try to get them enrolled in Medicaid, honestly as a benefit to them. We can provide them free care, but that only covers for services that we offer at our medical facility. When they're enrolled in Medicaid, they have access to care and payment beyond just services offered by Rutland Regional Medical Center. We also do have one of the most, if not the most generous free care programs in the state. We provide full free care to individuals and families with income up to the federal poverty level of 300%. And then we have a cost sharing up to 500%, where at 500% we'll provide 50% free care. So a program that we definitely focus on. We partner with our patients, really try to support them. We have advocacies in our financial counseling office who are certified to help enroll patients in both the exchange as well as the Medicaid program. Our cost structure. This is a high-level slide. We'll talk about a couple of the specifics. Suffice it to say, year over year, the rate of growth in our cost structure outpaces the rate of growth in net revenue. It requires continual reduction in your cost structure year over year over year, or you lose money. And that's what we're faced with here across the state. There are really three components in Rutland that are driving the cost structure. So we have physician, recruitment, making sure we have access to care. We've hired 13 new physicians in about 18 months. That comes at a cost, a recruitment cost, and a cost to get them on staff. Pharmaceutical costs. Pharmaceutical costs on average, the inflation is growing about 6%. But inflation is only a tiny piece of the pharmaceutical cost. New drugs coming to market are demanding a huge investment in that treatment for patients. New drug came out to treat individuals with stroke. It's actually a life-saving drug. It costs $60,000. We've administered it a handful of times. If you're that patient, you want that drug. But it is really costly, and it's something that we have to look at here. Labor costs. Labor costs, we're challenged to hire more staff than we are losing. We have a very mobile workforce right now. Mobile meaning there are ample job opportunities for nurses across the nation. And they're taking those opportunities. We have a competitive recruitment environment. We'll look at that. And as a result of that, we're relying on travelers. Right now in the House, we have 35 RN travelers. In our 2020 budget, we've included 25. The cost of a traveler is twice that of an employee. So digging a little deeper on the nursing recruitment, happy to say, proud to say that at Rutland, our turnover rate is less than the national average, and that is a huge benefit to us. I credit that to our nursing leadership, to our integration with our physicians, our nurse residency program, our magnet status, all really important work to recruit and retain nurses. But it's still not enough. We're seeing an aging workforce. The average age of an RN is about 45 years. We're seeing a mobile workforce, and we had about 35, 36 RNs leave for other opportunities last year. And we're seeing a highly, highly competitive recruitment environment. It is very unlikely that you will hire many nurses without a sign-on bonus, particularly new nurses, or without a commitment to repay part of their tuition. And that is the world we live in. And that's what we are really focused on. We don't have our programs all solidified yet, but certainly working toward that. Pharmaceutical. So we talked about pharmaceutical inflation. Here we have 4 drugs that we use day in and day out in our facility. Drugs, asthma, kidney, psychological, and cancer. And you can see the trend line in each of those drugs. 64% of our drug spend is devoted to the treatment of cancer in our organization. Treatment of cancer has an enormous amount of research dollars around it. New drugs come to market all the time. Those drugs are very expensive. And this cost of pharmaceutical care, we're seeing it in our own self-insured program. We're seeing it as a risk, additional risk in the ACO and the risk programs there. Here's how we get by. 340B. So for our organization and many hospitals across the state, 340B keeps the doors open. In 2018, we would have lost $8 million had we not had a 340B program in our institution. And in 19, $7 million. Across the state, $60 million come in for the 340B program against budgeted operating margins of 72 million. 0.75% of our operating margins are dependent on 340B. So a lot of criticism, a lot of question as to the validity of this program. Honestly, it keeps the doors open. It helps us to offer services that we know we lose money on: pediatric care, emergency room care, psychiatric care. It is vital to our community. It is vital to Rutland. It is vital to the state of Vermont. There are numerous federal policies that are looking to restructure this program, many of which would have a huge, significant negative impact to our organizations.
So some of the opportunities that we have are also some of the challenges that we have. And you'll see a theme, I think, through some of the things we're talking about. Our ability to develop data models and analytics is really at the center of our ability to be successful under the new models. And our ability to get that information out to teams so they can act upon it and have those teams available is the second step of that. So we have a tool built within our IT infrastructure called Healthy Intent that allows us to ingest data from a variety of sources, internal or external, and share that back with web-based applications that we can give access to our community. We're very excited about the potential there. We're starting to leverage that tool for our care management system, as well as the community collaborative more broadly. That includes a variety of other healthcare providers. You bringing data into that, analyzing it, and giving it back with trend reports and other kinds of prioritizations within it that help us focus our energies where they need to be. A key to that for us is making sure that we have data that we can get from OneCare that is timely and meaningful and at a level of detail that allows us to do those analytics. And so we're still working through that with OneCare. We have some data from them, but that's a significant challenge for us at the moment is having that data available to us. The second bullet here, Odyssey Community Health with H capitalized, CHCRR, has formally changed its working name to Community Health. And they are our biggest and most important partner in all of the work that we do going forward. We feel like our relationship with them is exceptionally strong, and that even though we're two separate organizations, we view our commitment to our community as a single entity, and we're working very, very closely with them. We think that's having community health as a partner allows us to accomplish, and covering more than 75% of primary care in our community, as a partner with the hospital allows us to do things in Rutland that would be a challenge elsewhere, I believe. Beyond that, we are extending the care management system to include all of our healthcare providers. We have in the community, we have a very robust community collaborative which engages all of the other community health partners in our community around shared goals. And we believe that that's a tremendous opportunity and energy in Rutland right now that we'll be able to take advantage of down the road. In terms of improving access to care, we have very good relationships as well with the skilled nursing facilities. They are part of our community collaborative, and we're actively working with a couple of them to try to develop programming or other kinds of supports to address the needs that we identified earlier, particularly with the avoidable days conversation. So some of the things that we're thinking about, for example, are if they can bring online these particular types of programming, can we support them through providing psychiatric consultation with the staff that we have at the hospital, which is staff that they don't have but would need? Are there other kinds of training things that we have as we've developed for our psychiatric technicians? Can we extend that training to some of our partners so they can bring on that expertise into their facilities and so forth? So those are a variety of things we're talking about. We're also talking about, are there ways for us to bridge the payments while a patient is waiting for, to get approved for long-term Medicaid? That can take some amount of time. We're looking at seeing if we can develop an arrangement whereby we would hold the risk and hold the skilled nursing facility harmless, essentially, on those patients if the long-term Medicaid was denied, which happens very rarely. So it's not much of a risk, but it's a significant barrier to getting patients placed at skilled nursing facilities. We believe that we have a competitive edge with physician recruitment. Our culture at our hospital includes physician leadership at all levels of the organization that is very engaged, very robust. We believe that the quality awards that we've been recognized for, that Claudio alluded to earlier, certainly also make us stand apart from other options that physicians have. And probably most importantly, in this era of news about hospitals that are having financial difficulties, our long track record of financial stability is part of what keeps us functioning and being able to recruit and hire and retain physicians. And so it's very important that everything we do continues to feed that. An opportunity for us is also telehealth and telemedicine in a couple of ways. So we're running some pilots where we are starting to provide services to patients via telehealth and telemedicine, and with patients in their home with our clinicians in their office. And we are also looking at various kinds of arrangements with tertiary care centers so that in some cases we might be able to provide specialized care in our hospital to our patients with specialty care providers that work at tertiary care centers, as opposed to having to hire additional staff within our own hospital. And lastly, our community mental health partnerships. I believe there's a huge opportunity there. Our community health center, our mental health center is certainly highly engaged in trying to expand their community-based outreach and crisis services, which is really important to us. More than 70% of the patients in psychiatric crisis that come into our emergency department ultimately end up going home. And if we can provide enhanced upstream and community-based services, we feel as though we could significantly reduce the number of hold hours in our emergency department, improve quality care for patients, and reduce the cost of the hospital for supervising those patients.
So with the challenges of recruiting, nursing in particular, we have a number of recruitment and retention strategies that are either in play today that we hope to mature, or programs that we hope to create and develop. Our nurse residency program, wonderful opportunity for new grad nurses to come to work at Rutland Regional Medical Center and continue their education and continue to or learn to integrate into the services of our hospital. It's a peer group, it's a support group. They also dig a little deeper into issues that we should address. We had our first graduating nurse residency class on Friday, where they displayed their work as a nurse residency program, looking at deeper issues that we should address: night shift, 12-hour shifts, nurse communication. All wonderful projects that allow them not only to dig deeper into day-to-day clinical issues, but also to develop a peer group and to develop relationships with leaders across the organization. Wonderful program. The AIRLO program, this is one we hope to get in development and active within the next few months. This is an incentivized program where we're targeting for our surgical nurses, which is a night and weekend incentive that as nurses you would enter this program and agree to work nights and weekends and be on call. It helps with morale and it helps with staffing across the nursing base within surgical care because it allows you to be off call more and it allows weekends to be covered. International staffing options. Our HR group with our nurse leaders are looking at ways in which we can recruit nurses internationally for long-term staffing arrangements which end up with full employment. Something that we are investigating. We've had a number of conversations on and we'll make some decisions on that program within the next few months. Specialized bonuses for hard-to-fill positions, not only bonuses, but tuition reimbursement. You need to understand where we can effectively recruit and retain nurses with something we can afford. And so we are looking at ways in which we can offer these incentives so that we can compete in the market. And with that comes leveraging Castleton University. They are our feeder system for our registered nurses. How can we better align with them, partner with them, to help us not only with recruitment, but to help us as we onboard those nurses as well? And how can we reduce some orientation time, increase just nurse onboarding, as well as really begin to integrate them into our community before they graduate. We have a couple of grow our own programs. As a magnet organization, we have a commitment to transition our nurses to bachelor degree, BSNs. And so we are supporting our associate degree nurses to gain their BSN. We are also have an LNA residency program where we're trying to grow LNAs into RNs, and I think we have 5 in that program today. On the cost side, we're very active in our group purchasing organization, Vizient, where we are active both on the supply side as well as the pharmaceutical side. And we look to participate in any of those cost reduction programs that make sense for us. We're active, we're at the meetings, and we bring that back to our group, and it is a major support to us being able to lower some of our costs. Greater integration with IT. IT is really expensive. It's hard to recruit individuals to our area. We are a Cerner shop. We are leaning on Cerner to help us with becoming more efficient. And that can mean many different things. It can mean more efficient in contracting, it can be more efficient in our use of the system, but really helping and asking them to help us to be more efficient and to reduce cost. Introduction of biosimilars. Jonathan Reynolds is leading this program with our physician partners. This is, biosimilars are, some would say generic, Jonathan would say no. They're almost similar. They're not exactly, but they've proven to have the same clinical results. And so we are working with our physicians to be able to begin to put these drugs and medications on our formulary. They're less expensive. And so we've got a couple of biosimilars now. We're researching a couple more. But this is a focus within our pharmaceutical inflation. Continued advancement in data analytics for cost. I would say cost and population health as well. We have just unveiled a procedural cost reporting initiative whereby the finance staff is working with physicians. We trialed that in orthopedics to begin to look at direct costs of procedures and to look at the variance of those surgeons performing those procedures and how can they learn from one another, and are there ways that it makes sense to standardize. And so that project is in its infancy, but certainly one that we're very committed to and one that we are looking to drive cost reduction through standardization. So our balance sheet, you have the full balance sheet in front of you. I will tell you that we have a strong balance sheet as we have high liquidity, low leverage. More importantly, we should look at our metrics. We'll talk about those in a moment. The cash flow. So cash flow, this is fairly vanilla here and not much. We need to continue to invest in our plant and our equipment. Our strategy is to invest 1.2 times our depreciation. We need to fund our closed defined benefit pension program so that we continue to manage that program and continue to position ourselves to have a fairly attractive out plan for that program. Sources, we are budgeting an operating margin of 6.7%, investment return of 6%, highly volatile there, and debt issuance. So this is the last phase of the medical office building. You'll see that last piece coming in. Please know that our operating margin is contemplated, and the need for cash really drives our operating margin. And that 2.5% margin, this is the reason, and it's really driven by cash flow. As we begin to explore deeper the financial performance and strength of the hospitals across the state, it's really important that we begin to really focus on trends and financial metrics and performances. And more so, it's important that we look at a whole host of them and not key in on any one metric. They tell a story, and each hospital will have its own story to tell, and each hospital is in a little different place. So the Rutland story, if we were to look at our balance sheet, you will see that we have strong days of cash on hand. But our days of cash on hand has gone down 17 through 19, 3 years. You can correlate that directly with not meeting our operating margin. And so when I say cash flow drives operating margin, this is a direct result of that. Our age of plant, we are a bit older than the state of Vermont. We know that. It's not something we've kind of turned the cheek on. We have a master facility plan that will help inform us where we should invest, and we will get back to the state median. Our medical office building project is well underway. And then our debt service coverage. You see this U-shaped performance here, this is a result of our operating margin. And so when your operating margin goes down, your capacity to take on debt goes down. And so a direct correlation there. One of the pieces that Claudio alluded to when we look at our balance sheet strength and we look at the pressures of not meeting operating margins is how do you accept greater risk knowing that you could have at a minimum $8 million in reserve. We do not have any reserves on our balance sheet now. And as we look at our balance sheet performance, this is a focus and this is a concern for us. So the budget summary we talked about, 3.5% net revenue growth, 4.2% budget to budget, expense growth, operating margin of 2.5%. We have not met that operating margin over the last 3 years, albeit we have had positive operating performance. And for us, a big piece of our ability to continue with some of our capital plans, regardless of operating margin, is our return on our investments. But that is very volatile and not something you want to bet on year after year. So in terms of operating performance, there are a number of metrics that you can look at. Volume, they're all skewed a little bit. You have to understand the mechanics of each of them. But just at a very simple state, if we were to count the number of different individuals or unique patients that we treated year over year for any service at the hospital, you would see that we're fairly stable. Now, I have to caution you that a patient is not a patient. A patient could come in once for a blood draw, or a patient could see us daily for chemo or radiation treatment. And so you have to look a bit deeper, but this is an indication of the stability of our volume. Unfortunately, what we're seeing and what we've demonstrated is that although volume is flat, what we're collecting has gone down year over year. And so the cents on the dollar, if you will, you can see 2017, 18, 19, a downward trend. 2020 comes in, that is a result of our cost-based reimbursement program with our psychiatric program and minimal return for the Medicare and the Medicaid program. But definitely a huge concern and one that also puts pressure on the commercial rates. And so that is, again, a focus. We have coding teams, we have billing teams, we have reimbursement teams that work day in and day out to make sure that we have programs in place that we don't leave money on the table. But honestly, the payers continue to provide more payment rules. The federal government, the state, it's really difficult work. I now can't see the screen. So FTEs per adjusted occupied bed. Although our cost structure has gone up year over year, it is not because we are not an efficient organization. And you can see that we have had a downward trend, and that is our discipline and our dedication to reducing costs. We reduced 15 FTEs, more than half of which were leadership and administrative positions this year. The difference between 19 and 20 is our need to invest in staffing for our psychiatric patients and that ligature risk. And that is the only reason why that ticks up in 20. Our pharmaceutical spend, you can see we talked about that. Again, just trending upward, a lot of pressure on our ability to meet our margin. And then interim staffing. And so this is our contract staffing. By and large, these are mostly registered nurses. You see it coming back down in 19 and 20. 19 are actual results based on some success in recruiting our nurses last year. And with those things such as the Baylor Plan, nurse residency, competitive recruitment, we're hoping to bring that down even more in 2020. It's not a for sure thing. This is a lot of work and a lot of commitment, but ending with 25 FTEs in 2020. And again, the cost of a traveler is about twice that of an employee. So in terms of what I consider to be living on fixed income, so we had a 3.5% revenue growth, and then you layer on the other operating income, which primarily is our 340B program. We have $11.7 million from which to spend for increased costs. So an enormous amount of work goes in through a number of months to decide how and where do we allocate these funds to make sure that we can be reasonable, we can continue to have a strong balance sheet, and we can return to meeting our operating margin. And so where we ended in 2020 is $2.3 million of that will go to physician costs. Honestly, those are physicians that are already here. Those are the 13 physicians in part that we've hired. And this is the cost of bringing them to Rutland. Staffing, 2.1%. It's only 2.3% growth, budget to budget. How did we do that? We reduced staff. We had that 15 FTE reduction and some fairly high-cost, high-salary positions, being leadership and administrative positions. Temporary staffing, we're seeing an increase, almost doubling there. Pharmaceuticals, based on both that inflation as well as new drugs to market and utilization, $4.2 million. And everything else, we're saying, is only going to go up 1% on average. This is not a slam dunk. This is going to cause us to commit an enormous amount of daily focus and daily discipline across the organization, but it is something that we think we can achieve. It wouldn't have happened had it not been for the leadership group getting together honestly in November and beginning budget preparations and beginning to understand where we thought we were going to end up in 2019. And the result of that is that we were able to cut $4 million from our cost structure. Some of those expenses are already included, and we have begun to see some of that expense reduction. Others will come into play. One of the biggest is our continued look to the 340B program, where we are working with the state of Vermont to be what we call a Medicaid carve-in, which means we can include the Medicaid population in our 340B program. At the bottom of the screen, and I won't go through it in detail, but you can see this is the work of our group purchasing organization, Vizient. It's the work of our purchasing and our pharmaceutical leadership, partnering with Vizient to bring cost savings to Rutland. Whole host of different ways, looking at new products, rewriting contracts, substituting some products one for another, and again, in total, about $4 million. So included in our 2020 budget, we know a bit more than we knew when we talked with you last year, but still not enough. But we have joined the ACO, as you know, as January 1st for our Medicaid population. Got about 7,800 lives. We receive about $1 million a month to take care of those patients. But then from that, we have to fund the care management. So out of that $1 million, on an annual basis, it's about $725,000 that goes to primary care. And then we track what would we have been paid in a fee-for-service environment versus what are we paid in a fixed payment. And for the 2020 budget, the impact of us joining the ACO, this is direct impact. This isn't everything we're doing in terms of public health and care collaboration and care management and those pieces, but from a financial direct standpoint, it's about $500,000. And that is a difference between what we would be paid fee-for-service, fixed payment. We actually are on the positive side in 20, is where we think we're going to come in. But then we have to take into account those withholds that go to primary care, because we do not employ primary care, so we get no funding through the care management program. And then $600,000 in ACO admin expense. And in this budget, we did include $145,000 of potential risk. How did we come up with that? It was about 25% of the $600,000. We have yet to see the total community spend. But we know we're running behind where we are on the hospital side, and we'll talk about that, and felt that it was our due diligence to at least try to give some type of estimate. I will tell you that it was 25% of our estimated risk at $600,000, but now that risk has gone up to $1 million. So really we're talking about 14%. Current ACO performance, as we sit here today, it's cost us about $800,000. Same lives, we haven't updated our lives. How did that come to be? So that withhold and through June is about $340,000. 277 paid to the ACO. And then we are running behind this year in what we would have been paid fixed payment versus fee for service. This information only reflects Rutland Regional Medical Center utilization. We have yet to see our community spend, which makes it extremely difficult for us to project for you and to include in our budget where we think risk could be. And again, we're looking at $1 million risk.
One of the requests made by the board to the hospital to explain was based on a report that came out from OneCare that showed the cost of care being provided within each health service area across the state. Rutland showed us in that particular report as being more expensive than other service areas. But one of the challenges, as I mentioned earlier, is getting clear data from OneCare about what goes into all those numbers and how that's being calculated. So we're the only community hospital with an inpatient psychiatric unit. We're unsure how those costs are being allocated to, particularly the level 1 beds, how those are being calculated in that analysis. We're also the only hospital that runs an outpatient hub or medication-assisted treatment center, and we're unsure how those costs are being factored into any of the projections made by OneCare. So, and that the comparative data is really over just for January at this point. So we are desperately trying to get that data and understand those numbers and how that's being calculated and where we are high, where we're an outlier, and what we need to address at a high priority. Having said that, we have a number of things that we're doing anyway, even though we don't know specifically what's going into that comparative number. So we have developed an organizational data strategy that integrates our financial data capabilities, our quality data, and our emerging population health data strategy. We have the senior director that's responsible for pulling together that combined data strategy. And we're going to be beginning recruitment shortly for a population health data analyst as well to help us understand, pull apart that data, and as I mentioned earlier, feed it out to the clinical teams that need to be changing their operations based on it. The other thing that we're doing is we're really trying to promote and engage our community-wide care collaborative. So in Rutland, we are very fortunate to have a high level of engagement, as I mentioned earlier, of all of our healthcare partners. On a monthly basis, we have a community collaborative stakeholder meeting, which has between 40 and 50 people every month that come to talk about our shared work together. There are, I think, 7 subcommittees, all focused on particular aspects of healthcare reform, improving the quality of health in Rutland County, that are very robust, very active. One of those committees is based on, is in partnership with Community Health, and it focuses on emergency room utilization. We think there's low-hanging fruit there for us to educate our community and our provider, our community at large, but also our provider community about the availability of express care or urgent care within our community, and significantly reduce the number of people who are using the emergency department as a surrogate for primary care or urgent care. We think that's a terrific opportunity for us, and we have work closely with Community Health to set some goals that we'll be working on over the next year. And also, so we have a formal agreement between the hospital and Community Health on a joint care management system. I serve as the director of that combined effort and report to a physician leadership board that directs the activities of the care management system. Within that, we've also identified Dr. Phil Lapp as our medical director for population health, and he is a partner that works with me to identify the priorities and strategies that we need to employ. We have a particular subcommittee of that group, which is focused between us and Community Health on ACO reporting and financial management, understanding the metrics that come out of finance, about how we're doing under the ACO model, and how do we align primary care and the hospital services to be most successful there. Our care management system is very active. We've done a number of things to align care between the hospital and Community Health. For example, we have hospital-based clinical teams now that follow a patient throughout the hospital and are aligned with primary care. So, for example, rather than if a patient comes into our ICU and gets transferred to our 5th floor medical oncology unit for follow-up care after they are stabilized, it was our old practice that you'd get a new provider, and you'd get a new care manager, and social worker. And there was no relationship to any particular primary care doc. We have now aligned that so that if you come into the hospital, you'll have the same hospitalist, you'll have the same social worker, you'll have the same care manager following you throughout the hospital, and those teams are aligned with specific primary care doctors, so that we really have a small team of inpatient docs and a small team of outpatient docs working much more closely together throughout a patient stay. Additionally, we align those teams across time, so that if you come in today, you're going to have the same team that you had last time you were here, and when you come in 2 months from now, you'll have the same team of care managers, social workers, and inpatient physicians that will be working with you. And unless you change primary care, that's the only way that arrangement would change. Lastly, we have a very robust implementation of our own shared care plan. We built a shared care plan that's a little bit different than the rest of the state. We built it within our EMR. We were very proud of the work that we did to pull that together. We have over 450 shared care plans at some level of engagement. So even though we are only at risk at the moment for Medicaid, most of our shared care plans, based on clinical need at the moment, are actually for Medicare patients. With the instructions we gave to our clinical staff was do the right thing, work with the patients at highest need, and the patients with the most complexity, and that led them mostly to develop those shared care plans for our Medicare population and not Medicaid population. Because of the increasing needs for data collection and reporting to OneCare, we're actually going to be changing from our own shared care plan at the beginning of the next calendar year and adopting Care Navigator. That'll create some challenges for us. We're a little bit disappointed with that, but we do see some advantages to working with Care Navigator in terms of some of the applications that they're developing and the ease of use of that tool. But we're not kind of getting credit at the moment in the OneCare system for this enormous amount of work we've done around shared care plans and the Medicare population.
So that really concludes our conversation with you on the 2020 budget. And we'll move into compliance and capital. But before we do so, I just want to reiterate where we're coming from. And as you heard Jeff speak this morning, it's a tough environment, and we haven't turned the cheek. We're hitting and meeting the challenges head on. We understand the pressures of rates for our patients. We are trying to hold down rates. By doing that, really focusing on cost reductions. But know that we're not crying wolf. It's real. Pharmaceutical inflation, recruitment, the bad debt-free care issue for these high deductible plans. And so together we've got to partner to try to get through this without jeopardizing the financial health of the system. So in terms of where do we think we're going to end in 19, budget compliance, we believe we will comply with the net revenue restrictions, and honestly, we will be very close to what we told you. That doesn't mean we're going to meet our operating margin. In fact, we think we're going to be about $2 million shy. And that is, again, that common theme of pharmaceuticals and labor pressures. And labor pressures showing in our financial statements through premium pay to our temporary staff. You will see that we've picked up about $2.7 million in that other operating line. That's our 340B program that we built into our 2020 budget. Shifting gears again, capital. Capital, we need to make very informed decisions with restricted dollars as to where we are going to invest on behalf of our patients in this community. And there are many more requirements or needs than there is funding. And so we were challenged with that this year. And for the first time in many, many years, we've commissioned a group to come in and do a full plant master facility study to help inform us as to how we invest in our plant, our equipment, not for today, but tomorrow, and where healthcare is going. We will receive the results of that phase 1 assessment in September. And because of that, I sit before you today and say we don't have a full-fledged 4-year capital plan. We're really trying to be very disciplined, very thoughtful, and have others help us understand where we're going to get the most value, the most quality for investment back into our capital. That may include things that we have in our 2020 budget already. And so we need to think about where those pieces are and just one more time make sure they make sense. In terms of active projects, we do have our medical office building on time, on budget. Really a nice project for Rutland, for the community, for our patients, our physicians. Replacement of our CT, this is vital, had numerous uptime issues. Happy to say that within the next week we will switch over to the new CT. Really important to our patients and our clinicians. Foley Cancer Center renovations, we're in phase 3. Again, this is for the benefit of our patients. These patients are with us every day for an extended stay, really trying to make their treatment and their care as comfortable as possible. Our community was behind that program as well and had a major capital campaign that supported that. And then just recently, we worked with you to assure funding for our psychiatric care renovations directly related to ligature risks that came out of a survey and a finding for our organization, as well as organizations across the state, even in Dartmouth, others. It is a federal program. So we are in the planning phases of that and hope to begin the project in earnest this fall. So for 2020, we are sitting on a routine capital of $10.5 million. 6.6 is related to equity-funded CONs. About $500,000 is going to come from fundraising and endowments, and then that residual 5.1 on our medical office building where we did issue debt. Over the past 5 years, we've invested about $84 million in capital. This is the lineup of our 2020 capital. I won't spend a lot of time on it. You see the $10.5 million in what we consider routine. We do place $2 million aside for contingency for those things that just happen that are hard to plan for, so that we don't have to cancel or rethink projects that we've already committed to. And then you see our CONs, 2 of which are in approved state, and MRI is one that we are considering now. You also asked us, I believe this was new this year, to tell us where you think we're going and what is our 4-year plan. This is a very formalized process that we have at our medical center, where each January we work with our board of directors to give them a strategic plan and a strategic financial plan, really highlighting those major efforts and major challenges or opportunities that we need to focus on. This is the result of that planning process. And what you need to know is that it just requires expense reductions year over year over year. And not only does it require the expense reductions, but they need to stick. You can't cut them in 1 year and they come back. And so this is where we're focused. This is what began the drive for the $4 million this year. We had a couple of million the year before. This is one of those drivers to that planning. You also asked us about compliance with Certificate of Need. I've got 5 projects up there. One is closed. We were under budget by $388,000 on our HVAC. We are soon to close our nuclear med project. We believe we are going to be under budget there. Medical office building, we've talked about that, on time, on budget, really early stages. We've got steel on the office building done. We're pouring concrete, but have yet to work on the loading dock for the renovations to any administrative building. CT scanner, again, that will come in service within the week, and we will begin using that, treating our patients, and then the psychiatric renovations. We do report to you folks either every 3 or 6 months, depending on the project. In compliance with budget orders, this is actually your slide. We decided to repurpose it for our presentation. But the 5-year average, Rutland Regional Medical Center net revenue, 3.6%. We are below your state average of 3.8%. And that concludes. So that really concludes our presentation to you.
Thank you, Judy. Okay, Robin, do you want to lead off the questions?
Good morning. I'm just going to start with a few clarifying questions from your presentation. When you were talking about the rate increases, you said that you restructured your professional fees to be consistent across the board. Could you just explain what you mean by that?
Sure. So we have various clinics and service offerings where we bill for physician services. They were not consistent in our approach. And so it really wasn't to raise rates. It was to make sure that we were consistent across all services. Some rates went up, some rates went down.
Okay, thank you. When you are now shifting to your recruitment slide, so I was interested to hear a little bit more about when you're thinking about retirements and new recruitments. Obviously, you look at the wait times that people are experiencing in your area, but it sounds like you're also thinking more strategically around what kind of services make sense to be offered at your particular hospital. So I was curious, when you think about that, what are your considerations in terms of service offerings? And in particular, when you're thinking about that, how do you think of that in relationship to payment reform moving to a fixed budget as opposed to a volume-driven environment?
Well, access to bread and butter urology services, for example, is important. I mean, sending people, and so where we're located, about 40% of our referrals go to UVM, outside of Rutland's health service area. About 40% go to Dartmouth, and about 20% go to Albany, New York. If it's for bread and butter urology services, keeping that basic functionality and that basic service in our community, we think, not just benefits the hospital and the community, but also benefits to bring their costs down. Once patients get outside of our system of care, and once they get outside of the one care ACO in particular, we lose some control, we lose some coordination over those patients. So that's what we're thinking on that. We also support primary care recruitment, although we don't employ them directly. We do provide recruiting infrastructure for them. And having the correct complement, Robin, of primary care providers is critical. I mean, a lot of the focus is away from specialty care towards primary care, and that's where, the nuts and bolts of care coordination happens. We're working to support that primary care infrastructure. So some of our recruitment efforts go outside of the directly employed positions.
Thank you. Shifting to the erosion of the commercial insurance, I thought I heard you say that the type of commercial patients that were driving the increase in free care were insured patients, not self-insured patients, and I'm wondering about that, because we know we have about 75,000 Vermonters insured through Vermont Health Connect statewide, which is, when you partial that out across the state, is not a lot of people. So could you speak a little bit in a little more depth to that commercial insurance component? Are some of those I would assume some of them are out-of-state patients, they're not all Vermonters, but do you have any more detail about that?
So I just want to clarify that free care does go to self-pay patients, and about half of our free care is provided to those patients.
When I say self-insured, I mean the employer is paying for like you guys are self-insured. I don't mean uninsured or self-pay.
So the commercial free care is coming from both a mix of self-insured, where we do have employers offering very high deductible plans, as well as the exchange, and those, as well as what those plans are. And the other piece that I think is important is there are many individuals who are enrolling in the exchange and maybe being covered for a few months and then not being able to pay their premiums. And so it's all three of those. It's the high deductible self-insured, it is the exchange, and then falling off the exchange, quite frankly. We do have a major contingent of out-of-staters, primarily being at the base of Billington, and they also bring to our facility high deductible programs.
Some of which you answered as we went through the rest of the I think I'm good.
Thank you, Rob. Tom?
I want to thank you for a very good presentation. It's a deep dive, very informing and well presented, and gives me confidence that the Rutland Hospital is well managed. I have a couple of questions on bad debt. The first is bad debt is always a difficult topic to discuss, but I'm looking looking at kind of your recent record, and you were from a collection agency able to collect $3.9 million according to your submission to the budget guidelines. And in 2018, you wrote off $11.7 million. And I'm wondering is that and it's a big jump in bad debt from $4.7 million to $9 million from 2018 to 2019. And I'm wondering if any of that might be related to the change in silver loading, where there was a federal cost sharing reduction program that no longer exists and is not very quick-footedly. You changed that to leverage the advanced premium tax credit. But I wonder if that the shift in those mechanics might have anything to do with the rapid rise in bad debt.
So it's not a program that we're participating in or even fully aware of. We've not investigated in Rutland. And so I just want to be clear, you're talking about attaching a withhold from Vermont residents' tax return to pay their medical bill.
Well, I'm not promoting that.
No, but that's the program you're talking about?
Well, what I'm talking about is that there was a federal cost sharing reduction program where you got assistance with the deductibles. The feds stopped that. And Vermont went to the advanced premium tax credit to leverage that because for people under 400% property, their cap is a percentage of their income. So the mechanics changed from one that relates to premiums from one that relates to deductibles. And I'm just wondering now that people kind of have to face the deductible in its fullness without any help from the feds, whether or not that's just changing, having an impact on that.
So I can't tell you affirmatively yes or no. It's something we need to look at. I can tell you that there is a piece of our bad debt that is bad debt because we can't get employees to work with us or patients to work with us to complete the requirements of the application. And that is really frustrating for us. We'd like to help those patients out. But it is, and there are many reasons why they don't. And so there is a piece of that bad debt that is kind of associated with what could be free care.
I mean, we're clearly seeing that, Tom. I mean, if you look at that progression from fiscal year 15, from bad debt and free care, it's not the free care part that's changing dramatically, it's the bad debt that's growing. So, the total was under $10 million, now we're at $16 million we project next year.
I noticed that. To me, it's a difficult asset to try to manage for because you are asking people to pay more. But when you have bad debt, somebody else is covering that cost somewhere else in the system. And so I am probing as to whether or not, my last question on bad debt is your financial assistance program tuned up in full compliance with any federal regulations you have to deal with? Or are there any options under those regulations that you could employ and have chosen not to employ?
So we've received a letter from the Healthcare Advocates Office, and we're looking to work with them over the course of this year on what can we do to make sure, A, we're fully in compliance with the requirements, and not just being regulatorily in compliance, but if there's some suggestions and ideas that they have that are just outside of the technical compliance, and we can make it easier for people to understand.
60%, $60 million cost share. And it's all in how you allocate costs to each of the programs. And so at a very high level, you're looking at revenue and then just associating a cost to charge ratio of every dollar billed. For the Medicaid program, again, what is included in there is the cost of the med tax program. And for Rutland, that cost is $15 million. $12 million. We pay $15 million. We get about $3 million back through DISH, but it is a cost that is continuing to grow. The state's funded that program for a couple of years, and it does have an impact to our margins, to our profitability, and it does significantly cost.
Projection is for all Vermont hospitals, $42 million in operating margin, 39.4 going to the University of Vermont Medical Center, which is 92.7%. And then looking at the net present revenue by hospital, the 2019 projection or the 2019 budget is and up across the system of only $2.8 million. But the up for the University of Vermont Medical Center is $23.9 million, which leaves the remaining hospitals, many of them in the red in terms of operating margin, and you can see that. And so some might say that that has to do with demographics. Some might say that that has to do with the bargaining leverage in the University of Vermont Medical Center. Some might say that that has to do with payer mix. The UVM Medical Center is a very favorable payer mix. I'm just wondering if you, because you're part of the system, and a fairly major part of the system, do you have any insights on that distribution and what might be the main drivers of it?
Well, first of all, I don't think it's a zero-sum game. I don't think it's, UVM gets, I think we all operate independently from that. And, different markets are different. I think the challenge, what we're seeing in healthcare in the state of Vermont is similar to the challenge we're seeing in higher education in the state of Vermont. And we are acutely aware of that in our community where we lost 3 small private colleges here in the past year. And it seems like what's going on in private education is, the smaller places are having trouble keeping their head above water. Same thing in healthcare. But we're not just, this is not a phenomenon that's unique to Vermont. I think this is a phenomenon that's going on across the country. And one of the things that is unique to Vermont because of geography and culture and so forth is that, we have a lot of small independent hospitals. And, across the country, hospitals are aligning to large systems. There's some benefits, there's some financial stability you get, but there's some losses you get from that too, as far as control and your ability to meet your community's needs. I've worked for both. So I don't know all you mentioned a number of factors that go into that. I think we are talking, hospital leadership throughout the state, have been talking to each other and saying, okay, are we stronger as an independent hospital or are we stronger to be part of the system? I think that's not a one and done. I think we all make those determinations, but I think we all are going back and revisiting that every year to say, does that still hold true for us? I will tell you, I think it is a benefit for the state of Vermont coming as a hospital administrator from an independent community hospital. I think it's a benefit for us all to have a strong academic medical center located in the state of Vermont. And I don't think any of the solution is to try to weaken UVM and thinking that that's just automatically going to strengthen some of the smaller hospitals. I don't think it's going to work that way. So my 2 cents on that, Tom.
Thank you.
I actually have a follow-up from Tom.
Sure, Rob.
As you probably know, I'm the chair of the Rural Health Services Task Force, which is a legislatively created task force to look at the sustainability of hospitals in Vermont and other healthcare providers as well. And one of the issues that we have not yet tackled, but I think will be on our agenda soon, is looking at the overall sustainability issues. And you mentioned healthcare having some similarities to education, and one of the challenges that I think we have to start talking about as a state is how what we value in terms of services in our community. How can we take more creative approaches to maintain access to a full range of services for people, but understanding that if we value having 14 buildings where they're currently located, that will drive expense in the system. So I just wanted to throw that out there, and then as a follow-up to what Tom said, to get any other thoughts you might have on that.
So I might respectfully push back a little that if we had 12 buildings, or 10 buildings, or 8 buildings, would we see less expense in the system? I think paradoxically, we might actually see more if you can't access, what we're doing in Vermont, other than UVM, which has its academic mission is doing tertiary care. What we're doing by and large is primary care, health care for all our community hospitals, critical access hospitals, and the PPS hospitals of Rutland. So I think my theory is that if you didn't have that, coming from the Northeast Kingdom for 10 years, some of those people would not get care if they couldn't get it at their local hospital. And we've seen, cardiac patients that have said, Doc, do the best you can. I'm not going down to Burlington or to Dartmouth. Take care of me here. I don't want to have a lot of stuff going on. So, it is a significant challenge for our state. And I've been in a critical access hospital and now a PPS community hospital. But I think we're all trying to find ways, Robin, how we can deliver that health care more effectively. Telemedicine holds some promise, and we've had some limited success in employing that to try to continue to provide services and bring the costs down. And we at Rutland are looking at all those things as well.
Thank you.
Do you have more questions, Tom?
No.
Maureen?
This one. First, I really want to thank you for a very thorough presentation and the fact that you continue to stay within the NPR compliance guidance that we've given you the past couple of years and not relying solely on the commercial rate changes to get there. A couple things I wanted to dig into. On your discussion about 340B, just really getting an understanding of it. I know you see it in the other revenue side, and you also explained in your expenses part of the reason for the pharmaceutical increase was 340B as well. So just when you talk about the total impact for 340B and what it is to your bottom line, are we offsetting both of those? So can you give color kind of on what you think it is in the revenue and what you think it is in the expense, in a high level?
Sure. So the 340B information that we provided in our slide includes both what we call retail, where you have an expense component that offsets your revenue, as well as savings on drugs that we administer to patients within our 4 walls. Drugs provided to our patients, there's no revenue for that. It's an expense savings. And so we are able to buy and purchase drugs at a deeper discount than we can average wholesaler for purchasing.
Because when you look at this chart, right, which is saying if we look at 2018 actual, where you came in about 2 million, but you would have lost 8 million, so you're saying the net of that would have been about a $10 million contribution, putting both of those together for 340B.
That is correct.
Okay, all right, thank you.
And so to that, I'm not sure that the slides that were provided through your office include both sides. Yeah,
That's probably true. Just talking a little bit about the ACO and just trying to get to the page on the ACO performance deck that you did. Just want to get your perspective on a couple of things. One, right now the risk level that you're carrying is fairly low because you're only in one of the programs. And what have your auditors told you about if you were to go to full scale and potentially had, $8 million in overall risk? Would you need to be accruing for that each year? Would you be potentially using your balance sheet to offset it, ultimately running it through your P&L if you had to incur costs? Or, have you talked about that with your auditors?
Yes, so we have. Unfortunately, we are in a difficult situation, we being Vermont, in that we're taking on risk, but we don't have all of the information that we need to understand what that risk really is. So as we sit before you today, we are 8 months into our program. We don't know what our risk is. We haven't seen the spend in our community. You are right, it is minimal this year, $1 million. We're treating this as really a training, as maturing our data analytics, working with our community health partners, trying to get care management up and running so that we can mitigate that risk of, and I say 8 million, I think that's the low end, and mitigate that, because then it does become significant, and risk at that level wipes out our entire bottom line. From an auditor standpoint, we need something to justify. And so we will go into year end this year with some information that OneCare provides. And as long as we can justify and have some information that supports a risk or a reward, we'll use that information. You cannot build reserve that you do not have any justification for. And that is one of our challenges here as well. And how do you go from not needing a reserve to an $8 million reserve in a year without being able to build any of that in advance? It all comes off of your balance sheet.
I'd like to add on that, Maureen, if I could. I think over the course of this year, my thoughts would be, to get us all on the same wavelength, the providers, our auditors, you as our regulators, and the ACO, to talk about what's a reasonable way to get from where we are right now to where we need to be to take on risk, so that we're all aligned in that. So I think that is something I would propose we work on together over the coming year, so that we can assume up risk and we can be covered financially for that. We have all the other issues about assuming risk, the operational issues that we have, but this might give us some financial comfort in how we get there.
No, absolutely, and that's something we want to work with you all on as well. On your chart about the budget impact, where you had your monthly fixed payment of about $12.3 million, and then the fee-for-service rate at 11.3, and that's obviously for what's occurring within your hospital. I like that analysis, just wanted to get an understanding on, is that what you're projecting for 2020? And then I know for 2019, you actually said it was a little bit unfavorable. And how are you coming to that? Because we haven't really seen this laid out like this from other hospitals, and I think it's important to be able to see not just the risk that's occurring outside your hospital, but what's going on, within your doors.
Certainly. So you are correct. We think that we are going to be able to spend less or incur fewer charges in a hospital setting than fixed payment. But those will support the care management as well as the administrative fees, putting a lot of pressure on our population health team. The initiatives that Jeff spoke to you, integrating with community health, hiring a top health analyst, hiring a medical director, looking at ED utilization, looking at readmissions. There's an enormous amount of work going on. And that work we've kind of bet on, saying that is going to impact our utilization.
Okay, and then just a couple more. One on cost savings, and I know you use an outside consultant, Vizient, right, to help you with that. I just wanted to get a little bit of an understanding on how that works, as far as do you pay them as a consultant, do they get paid as a percentage of savings, and what can other hospitals in the state kind of learn from, or do you see areas they could leverage as well to get savings?
Yes, certainly. So each contract is a little different. There is a cost associated with our involvement, our participation. There was an upfront cost, there was a capital call a number of years ago that we funded to be part of this consortium. Going forward, it's our ability to participate in these contracts. It's a high volume game. The more hospitals they can get to participate, the more leverage they have to negotiate. But there is an annual cost our benefit exceeds any annual cost. And here's an actual example. So that we passed on increases related to the acquisition cost of supplies. Across all of our supply categories, the increased charge to the patient on average in total was $50,000. That is a direct result of our participation in this program and our ability to leverage discounts because of group purchasing.
And then the last one is on, you talked about unique patients and that your unique patients were fairly flat year over year. And what you didn't really talk about was your case mix index and utilization and how that's changing. And on one of your bridge charts, we can see utilization is up. I guess you did talk maybe on one of the slides about 7 million. Also there's been a push by some of the hospitals to maybe look at a PMPM metric for measuring, year over year, and as another guide. And would you be able to do that, or what's your thoughts on that?
So a lot there in that question. So let's talk about unique patients all being unique, and that is certainly the case. What we're seeing is what I would call good and bad volume. Good volume are those patients that come in, we can treat them fairly efficiently, they have low length of stays, they have great clinical outcomes, great quality outcomes, we don't see readmissions. The challenging is the individuals, and in the month of July, we had 11 patients who were with us every day. Many of them are still here. Half of which are psychiatric patients, half of which are the patients Jeff talked to you about, the level 2 patients having a hard time placing. That's not great volume. We are seeing some increase in that. In terms of our case mix index, honestly, we're fairly flat. The patients we were treating last year are the patients that we're treating this year. If you look at who we're treating, psychiatric, substance abuse, orthopedic, cardiology, those are our drivers. Things that we look at there, we were in a congestive heart failure bundle. We looked at that, looked at our readmission rates. We're looking at our hip procedures, knee procedures, looking at how we can bundle, working with an insurer there on that project. But an all-in PMPM, it's kind of what the ACOs do. And so we are positioning ourselves for that. We don't think we're ready for 2020 because of that risk and because of still trying to mature and perfect, and probably perfection is not something we'll ever get to, but certainly mature those integrated care models, case management, affiliating with primary care. We are different in Rutland, and I know you hear that with every hospital, but we do not employ primary care. And so that in and of itself has some opportunities for us to work a little differently. I won't call it a challenge, but an opportunity certainly for us to deliver care a little differently.
Thank you.
Okay, Jess.
Up next, okay, great. So first of all, I want to actually echo some earlier thoughts about, I know the effort was required to meet our compliance, and I appreciate that very much, and I applaud all the cost savings and the use of data as we try to enhance care management, the relationship we're building with community partners at our skilled nursing facility, and I'm anxious to hear about the results of this pilot project to standardize care to reduce variability to try to improve cost savings. So a lot of great things that I heard, as I always do, from your presentations. I wanted to build on a couple of things that I've heard from some of my colleagues up here on the board, and a trend that we're hearing even from Jeff Teenan's opening remarks. So where is the world of future rural medicine going? And Claudio, you have a unique perspective, having come from, a critical access small hospital in the Northeast Kingdom now to Rutland. And as I think about our population aging and declining and medical technology becoming more and more expensive, my question to you is, we've heard about the 102 rural hospitals that have closed. What are we going to do in thinking about what is the future of the rural hospital? What services should we be expecting a rural community hospital to be providing, and what should be outsourced? And I ask this question in the context of a lot of what I'm hearing today, in thinking about, you mentioned, urology is the bread and butter, right? Is it, if you need robotic technology to recruit a urologist, is it bread and butter? Should it be something that's done at every community hospital, or is that something that needs to be outsourced? So I want to ask you that first to start, and then a follow-up question.
Yeah, no, great. We spent a lot of time thinking about that. And I don't know as if I can answer that question, because I think the jury is still out on where that is. I mean, there's some things clearly. We used to do diagnostic cardiac catheterizations at Rutland Regional Medical Center. We stopped doing that, primarily driven by the clinicians themselves, the cardiologists themselves, because as things evolved and developed, I think they weren't doing enough volume that they felt that they could continue to maintain proficiency, and so we didn't think it was in the best interest of the patient to do that at a small community hospital. There are some of those procedures that are there's pretty clear clinical guidelines that if you don't do a certain volume to stay proficient, you probably shouldn't be doing them in a community hospital. General orthopedics, joint replacement, those type of things. I think it depends. I think it depends upon the caliber of your organization, your physicians first and foremost, the productivity of them, and the focus of your system to be able to provide the pre and post-operative care, not just the joint replacement. So at Rutland, we have some of the highest paid orthopedic surgeons in the state or the region, but we also have the most productive orthopedic surgeons in the state or the region, and we align their payment to their productivity. I think it is, and they are very engaged as far as costs. Unlike some groups that say that's your problem, administration, our orthopedic surgeon group wants to be at the table, and they've actually been working over the past year very closely with Judy and actually pushing Judy to really try to get their arms around the cost of the procedure. What can we do to drive the cost out of the procedure? And they're really very willing to look at that. So, I think that, and especially as we've seen now with some of the ACO data that we have gotten, that some of the cost of the knee replacement isn't just the implant itself and the surgeon's time, the OR time. Some of it is in, especially the post-operative course of care and the rehab course of care. So, if you can keep that in the community and coordinate the pre and post-operative parts of that along with looking at that, I think we have a better chance of trying to bring the cost down. Not every hospital should be doing that, you're right, but I can't tell you where the line is. But I think probably we could work collectively on identifying, there's some national data out there as far as volume, where you should be, but we could probably look at some parameters. Where is the point where you should be doing orthopedic procedures and urological procedures and cardiology procedures and so forth?
Well, that actually was my follow-up, because you've mentioned a lot about access, and I think access is very important, but access is not at the expense of quality. So, for example, in Germany, they don't pay for, they don't allow hospitals to do knee replacements unless they do 50 of them. A surgeon does 50 of them, so they have these minimum volume standards. And so I worry about this in the context of, as our population is declining, is there enough critical mass in a hospital to be performing the procedures at a high enough quality level? And so I wondered if you had minimum volume standards for procedures, surgeon-specific or hospital-specific, that you think about at Rutland.
I don't think there's a lot of bright line data on there. I think the medical staff actually does a pretty good job, a very thoughtful job of looking at that. If we had a surgeon that wanted to come in and take on a new procedure, as far as what would they require to give them credentials or to recommend to the our board to give them permission to do that procedure, and they would look into the, is there any literature out there that there's been some studies, empirical studies on what you need? Do some of the societies have recommendations? But it's a multifaceted, there's a lot of factors that go into play there. Not just the skill of the surgeon, but the skill of the organization taking care of those type of patients.
So you have to have the team. The team has to be also qualified enough to be able to perform those.
So bariatric surgery is one of those things. We have general surgeons that technically perform bariatric surgery. And certainly there's a lot of candidates for bariatric surgery, but that is one of those things that it takes more than just a qualified, skilled surgeon to do that. It takes, preoperative counseling and so forth, selecting the right cohort, and then a lot of post-operative work. So it is a big program to do. So each one of those type of services warrants its own kind of investigation, but clearly we have to be judicious in what we're doing.
I just think as we're moving towards population declining, we have to think about it even more so in some of these areas. So I wanted to ask you a little bit about your healthcare area, health service area cost and utilization slide. And I think Jeff, I think you talked about it. One of the things that we put in our hospital budget guidance this year was actually the total cost of care per capita amount and the growth rate, and asked all the hospitals to comment on the trends that they're observing in theirs. Your slide talks about OneCare data that you received about Medicaid, but in fact the slide or the data that we put out in our hospital budget guidance covered all three payers. It was a residence-based analysis. It was based out of VCures, so it didn't have everybody in there. There were a lot of caveats associated with it. But even in that, with that snapshot view, the total cost of care per capita in Rutland is the highest, I believe, in the state, well above the median. It was $575 versus $484. And the growth rate was quite a bit higher than any other health service area. So I'm wondering, I appreciate this slide and trying to figure out what was going on with the Medicaid population, but wanted to hear what kind of analysis you did about all three payers. In a similar analysis, the Blueprint for Health looked at total expenditures per capita in the community profiles, and Rutland is pretty high up there as well. So what is driving, that's risk adjusted even, so I'm trying to figure out what is driving the per capita, even risk adjusted healthcare costs in your service area, recognizing not all of it is happening at Rutland. This is a resident-based analysis, but what you all uncovered beyond this.
I don't know if Jeff can help us with that. I don't have a clear answer for you. I've seen that same data, and we're starting to bring that data to our community collaborative and some of our groups that are getting together from our different providers and our partners in the community to look at that. But we haven't been able to dig into the data close enough to look at this. I mean, we're looking at some of the variables in there, but we probably need to, as an organization and as a health service area, look on a more macro scale and look at that. We're looking at little factors as far as readmissions and so forth. But so, Jeff, do you have anything to add to that?
So I will tell you, there's significant pressure on our rates. When you said reduction in high-end imaging, there's a lot of pressure there. We have 7 open contracts with commercial insurers right now, looking for access rates, fee schedules across the board. And so with that comes the need to control costs. And so they really go hand in hand. And it is why we look at our 4-year plan. We do need to bring down the cost of care to stay competitive, to stay financially strong. There are lots of pieces and parts. Some of it is cost and efficiency, some of it is standardization. There's a piece around readmits, we have our level 2. And so it's not one answer, it's all kinds of answers, there are all kinds of people working on them. But certainly something that we do understand and we are focused on and really challenged with laying it out.
Well, I appreciate that. It sounds like some of the things we've already talked about, you're digging into it, some of the variations that might happen in practices. Can we just talk a little bit, since you raised rates, I'm trying to reconcile in the appendix 8, where you broke out the charge request, so it was 2.65, and I don't think you have this in front of you, but I have it in front of me, the narrative. And appendix 8, requested change in charge from 19 budget to 20 budget. Hospital inpatient was 1.1%. Hospital outpatient was 1.42%. Professional services was 0.11%. If you actually sum those up, you get to 2.64%, but I don't think that would be how you make that calculation. But that's what's on this, in this appendix. And then in the slide, you talked about 2.65% increase, but some rates were going up and down, but across portfolio of services, it would be 4.25%. So I guess I'm just trying to understand a little bit more about how to reconcile all these pieces. So I really understand what the real rate increase is here.
So the first appendix that you looked at has some weight adjustment into it. It's not just out of.
Yeah, well, I do that because that wouldn't make any sense, but I couldn't figure out how you got to 2.64 with everything under 1. So I guess it's
and in terms of, it's not an average of 4.25, it's all other.
okay.
So when you look at, the 10,000 charges that we have, there's a piece related to high-end imaging that actually go up. I'm sorry, go down.
Yeah.
So a reduction. Pharmaceutical and supplies. Supplies really flat, as I alluded to before. Across all of our supplies, we only have about a $50,000 increase related to that cost. Pharmaceuticals do go up. Restructuring, again, this was more standardization. Anything else that I didn't mention has a 4.25% rate increase.
Okay.
So it is the average of all of those components that will equate to 2.6%, 2.65.
So the portfolio increases by 2.65%. We will have next year no more than 2.65% overall increase from rate. You look at all cost information. Makes sense?
So I'm following up on it just because I struggled like Dr. Holmes did on overall this was an incredible presentation and great work, but figuring out the change in charges was really difficult. And when you compute down to 2.65, is that doing a weighted average of all volumes to get to there as well?
No, the 2.65 is price. So if we first do consider volume, and that's the $7 million for mix of services and volume, and then we look at and reimbursement. What are we going to pick up for Medicare, Medicaid? That was $1 million. Our site, the difference between that and the 3.5% is what we consider to be our rate requirement, our rate increase requirement.
So maybe I'm really being tense here, but I'm still struggling. At the end of the day, your total income brought in by the increase in charges, will that be at 2.65% increase?
So if we go back to this slide, at the end of the day, if you were not to approve a rate increase for us, we would be shy $2.7 million of net revenue. $2,758,000.
Okay, I'm still, I think you're saying the same thing, but we're coming from two different worlds here. One of the things that's been very troubling is to see the increases that have been asked for, not only in QHP filings, but other filings as well, and double digits in the insurance side, and see what hospitals are being held to. So I just want to make sure that at the end of the day, if you were to average out all the increases across all the procedures, including the volume, that it comes to the 2.65. Claudio shaking his head, maybe is that true?
It is, based on the volumes that we're projecting, yes.
Thank you.
So let me just actually, it's still about this commercial rate, and in and of itself, 2.65 is not, I mean, inflation is more than that, medical inflation is more than that. So it's not the number in itself that's troubling, but here's my question to you. The reason that you're needing to recover, or to ask for the rate increase, as you described, is the free care, right? Many people are coming in now and can't cover their co-pays and their deductibles. And Rutland is known, through various reports that we've had in the past, pay parity reports have highlighted Rutland tending to be on the higher side of the price. In answer to the healthcare advocate's question, the ratio of your commercial reimbursement to Medicare was, I think, 238% for Blue Cross Blue Shield and 287% for MVP. So for every $100 that Medicare might reimburse, you would reimburse, if my understanding is correctly, 287 if it was an MVP patient. Is that right? Is that how I should interpret that? So looking at that in comparison to what other hospitals responded, that ratio was high. So my question to you is, have you considered or done any analysis of what would happen to the amount of free care that you would have to deliver if you actually lowered your prices and people could cover more of their expenses? Or have you thought about, is it actually driven by the fact that your prices, your commercial charges are high, and that's driving some of the need to recover this? And I guess my other question is, are you setting yourself up for a vicious cycle where now the rates go up and fewer people can cover it, and so next year there's going to have to be a higher rate increase to cover the more people that can't pay for their deductibles and their co-pays?
So I don't think that the rates, certainly they matter. And I testified before that we're very concerned about adding to the burden of local businesses providing health insurance and adding to the burden of local families trying to pay their medical bills. But I think the challenge is that the out-of-pocket expenses on commercially insured health insurance has gone up so dramatically. So, when you have to pay the first $2,000 out of your pocket at once, does it matter whether that MRI is $2,000 or $1,800? At the end of the day, certainly the rates matter, and we're actually looking at the reason why this is confusing is we're identifying those areas that historically were higher, because I think what's happened is historically, in the past, organizations have applied their rate increases on those areas where they get the biggest return, and a lot of it was in high-cost imaging. So we're trying to bring high-cost imaging down, and so that creates a significant challenge. The challenge is those rates don't just cover bad debt and free care, but they cover the pharmaceutical costs, they cover keeping a workforce and some of the workforce and the physician pressure we've had. So I don't know if I did.
No, it's tough.
Came close to answering
I know, I'm asking you tough
questions.
questions. I recognize.
So I would ask you to look at it a little differently. Bad debt, it's a visible number. We could also tell you that we need a rate increase because cost shift. And if you look at $1 million of reimbursement that we're picking up, primarily on the Medicare program, on $100 million of net revenue. So we're picking up 1%, but we know through our cost structure that costs are going up 4%. And so it was easy from a visual presentation to say it's bad debt, but really there are many factors involved. And Medicare and Medicaid do contribute year over year over year.
No, the cost shift is real. We fully recognize that, and we're collectively worried about it. My last question. About a week ago, I think CMS announced some efforts to reduce some of the burden on rural hospitals through a wage index boost. And I'm wondering if that, and I don't know enough about it, but it's expected to, in some states, to increase revenues in the millions of dollars. So I'm just wondering, does that affect Rutland, the wage index boost that they're getting in their reimbursements? I think it's the inpatient rule that just changed. Is that going to be helpful at all to you? I'm hoping.
So we have not fully evaluated that. There is a piece of wage index in the proposed rules. But I will tell you, on the flip side, the outpatient proposed rule, moving hips from an inpatient only to an outpatient procedure, if that were to go through, that is a $1.3 million decline. So anything that we would pick up in wage index would pale in comparison to that.
Thank you.
So, Claudia, you spoke with pride about the productivity metrics that you had for the positions. And I just want to question whether there's any incentives in those metrics for productivity that would encourage volume.
They could. Straight answer.
That's kind of what I figured.
But I think there are enough other controls over volume. So when you look at some of the micro metrics that we do see, and some of the citations that you cited, I mean, use of high cost imaging, we are lower than the average. You know, if you look at joint replacement and so forth, I feel very comfortable with our utilization review and some of our quality oversight. You know, we're not doing procedures. I think our physicians in Rutland Regional, general in the Northeast, but in Vermont, but they're not out there just trying to drive procedures in order to drive their volumes. So, you know, certainly they could, but I think we have enough oversight over utilization and there's other metrics that we're looking at that are not, that are countering that.
It's kind of an interesting thing, because when you talk about defensive medicine, every doctor will tell you they don't use it, but all the colleagues do. It may be somewhat true as far as some of the incentives for productivity. On that same vein, what kind of firewall do you create knowing that you have such a revenue stream from 340B to ensure that there isn't, I don't really want to use the term oversubscribing, but maybe not necessarily the best subscribing. You know, one of the examples I would cite is very different. A few months ago for a traveling board meeting, they're doing a pilot project with UVM about antibiotics, and they were able to reduce their use of antibiotics by 50%. So I'm just curious what type of firewall you have in place to make sure that as a way to generate dollars, and I acknowledge that there's no mission, that there's no margin, but how do you protect against generating dollars in that 340B program?
Yeah, so I think there is no incentive for any of the people who really control the prescriptions, the providers. There's no incentive whatsoever for them to prescribe. There's no type of incentive for them on the type or the volume or the cost structure of the drugs that they're prescribing. As a matter of fact, you know, they're looking at biosimilars, and they're looking at other lower cost drugs that they can prescribe. And then there's you know,
when they're looking at those biosimilars, does it ever come into play in the conversation what the reimbursement is to the 340B? Is that kind of the conversation?
I don't think so. When we're looking at a clinical side of the picture, no. I think we're the way we are looking at 340B is more through Judy and the finance folks and our pharmacy folks. We want to make full utilization of 340B pricing, yet there, and while at the same time being in compliance with all the very strict and changing federal regulations for how we run the 340B program. So it's pretty separate from what we're doing for clinical initiatives. You know, antibiotic stewardship is a clinical initiative that's going on in Rutland Regional, that the pharmacy staff and the physicians are looking at that. But it's very separate from, you know, those two discussions don't intersect as far as I'm aware. When it's, you know, we're going to do antibiotic stewardship, but what's the impact going to be on 340B? That conversation has never crossed my radar screen as the CEO for the past year and a half.
Super, that's good to compliment.
So, you know, we actually pay some of the bills for those physicians who are prescribing. We have on-site retail pharmacy used primarily by our own staff to fill their prescriptions. We're self-insured. So although there's a 340B benefit, there is a direct cost for us supporting that. On the inpatient side, there is no revenue generated. It's in the hospital side, there is no revenue generated. It's cost savings. And so there are various pieces and parts of 340B overall that can be quite complicated to comprehend, but it is not a revenue generation piece of focus whatsoever.
Thank you. Claudia, I also want to thank you for pushing back a little bit to my colleague, Dr. Holmes, on
No thanks necessary.
I would hate to see that if I need to go see a urologist, that I would have to go up to Burlington and have the second biggest hospital in the state of Rutland. So thank you for that.
You think clear about it?
Well, I'd like to know that all Vermonters would have access to that type of care at some point in time. But with that, that's a good point, because I do want to drill home the fact that over time we're moving more and more to trying to change the metrics for how we measure what we do as a board. And it's clear to see that the evolution is going to occur over time where total cost of care is really where we need to be. We need to be looking at per capita expenses. So the fact that Rutland is high on all of those measures is something that I hope you continue to look at. Judy, you mentioned that part of the savings were through a reduction in leadership positions. Is that C-suite or VP positions, or is that middle management?
Yes. No, we reduced a director in the C-suite a little over a year ago, and we also tried to model. I mean, we started talking to our staff about trying to, you know, a lot of this so much of our cost is labor. If we're going to achieve, you know, we can do so much on the supply side of things, right? But we really need to fundamentally relook at how we're spending labor dollars. And so when we look at a position that might have been in the budget for a long time, and when that position becomes vacant, what we're asking our staff is to take another look, take a step back, rather than just putting in to refill that position. So when my administrative assistant left, we looked in the C-suite how we could restructure, and we took the administrative assistant from the Human Resources Department, and they combined their job. She came over to work with myself and our VP for facilities. So we netted not replacing a position when we went that route. And so we were trying to model that and look at, especially areas that are not direct patient care, how can we bring overhead down when we have those opportunities. So yes, we took out a leadership position, we took out a support position, and as a matter of fact, you know, we're trying to not have this come from the direct patient care front.
So, sure, Lori?
Just as a follow-up, so was the majority of that through attrition or through strategic determining, where maybe the right staffing should be and then eliminating, people?
So a little of both, and we're working on getting, we're looking at getting more sophisticated on benchmarking our labor costs to, there's some benchmark providers we'll need subscribing to. So we're looking at getting a little bit more, better data on that. So right now, it's been a little bit through opportunities and, strategically where we think we can drive this, but we're going to focus more on that, and we need to focus more on that.
So at this point, and I'll just, before I go on, I will say that you have the disadvantage, Claudio, that I can remember when Rutland had one VP, Alex Nealon. So it's, you take a look at the last decade and a half when the statistics show the growth in administrative costs at hospital has far, far exceeded all the other costs, especially when compared to the physician side. It just, administrative costs in general are something that we always strive to keep to a minimum amount, because that's really the part that's not the direct patient care. So anything that you can do on there is greatly appreciated. Before I turn it over to the healthcare advocate, Patrick, do you or your staff have any questions?
No, we're all set.
Thank you. Mr. Healthcare Advocate.
Thank you, Mr. Chair. So let me just start by thanking you for the good presentation, and I also want to recognize and thank you for the answers to our questions. Your team did a particularly complete, thoughtful job in answering those questions. Appreciate it, recognize it. I also want to recognize and appreciate your track record on free care. Not only is your 100% eligibility better than the rest of the state, your track record on the relationship between free care and bad debt is particularly strong. And I suspect that that is not just because of your eligibility standards, and not just because you allow all Vermonters to apply for it, and not just Vermonters in your hospital service area. But I suspect that it's also because of some other efforts that you're making that are better than the rest of the state in driving people towards the free care, your free care program. I just would welcome any comments you have about that. And I want to say, like, far and away better, like significantly better.
So we have a financial counseling office that is in prime location. They are on the first floor, very accessible. We've worked hard with our clinicians to partner with them. We will often have clinicians bring patients down to help us help them, so to speak. As I alluded to before, free care is not our first option. We really want to enroll them in Medicaid so that they have services for any insurance for any services that they are seeking. But suffice it to say, when all else fails, we do engage with them. Our financial counselors are certified for the exchange. They have good working relationships with the Medicaid office. They also don't stay put in their office. They are in the clinical units, accepted by the clinical units, helping patients, whether that's in the ED or the psychiatric unit on the floor, where they're looking for patients who do not have a payment stream and looking to help them enroll. This isn't a collection effort. This is really an effort to find some type of insurance for them.
I appreciate the exchange that we had earlier. I look forward to continuing the conversation about your free care program and learning from you about some of the good stuff that you do and striving to make it as good as possible. So I want to follow up on the chair's question about 340B with just, and I heard your answer about the potential for driving more traffic towards pharmaceuticals because of that. And but I wanted to inject the additional piece of information that Milliman, a recent report nationally showed almost a 3-to-1 higher pharmacy spend in 340B hospitals than non. And just with the question, that's national, that's not Vermont, is there a risk of that here? And do you have a comment about why it would be such a strong number nationally and not showing up either at Rutland or in Vermont?
I can't comment, I haven't seen the study, Mike. I'll just tell you the culture of our organization and the focus on the partnerships we have with physicians, the way that the medical staff takes their responsibility for quality oversight. There is no connection at our organization between 340B utilization and incentives we pay to anyone, or whether overt or implied type incentives. We're not driving docs to prescribe a certain drug because it's on 340B. So, yeah, certainly that would obviously be the concern. The other side of 340B is collectively it's enabled us to do some things in Vermont that we would not be able to do without the revenue stream. And, we saw Springfield Hospital this past year close their OB unit. We cannot see that happen. And we see that happen. That's one of the first things hospitals go to do when they're running up against cost pressures is they look at doing things like that. Vermont is, when you're up in the Northeast Kingdom or when you're down in Rutland, it takes you an hour on a good day to get to the next closest hospital. Those programs enable us to do that at no taxpayer expense. So, we want to fully utilize it, and we spend a lot of resources to make sure that we are fully in compliance with all the very intricate, somewhat arcane regulations that we have, but we don't want to abuse it.
Okay, thank you. And then lastly, I don't know how to keep separate the national news from this proceeding, and I just want to recognize, two national efforts that appear to strive to reduce access to care. And one being the Title 10 gag rule, which is going into effect today, and the other, which the Healthcare Advocates Office commented against, and the other being the public charge conversation for New Americans, which could lock people who would or discourage people from accessing care that's available to them. I know that Rutland Hospital has nothing in particular, that comment is nothing specific to Rutland Hospital, but you have a particular perch on viewing the world of healthcare and the world of access to care, and we welcome any comments here or later about those kinds of efforts and what we should do about it here in Vermont.
So I'll be honest with you. Sometimes we're so focused on just our operations and the mechanics of keeping the hospital afloat. Sometimes we miss the bigger policy issues and what's going on. Certainly, I think, especially in healthcare today, especially in Vermont, where we're not-for-profit community hospitals that have community boards of trustees that want to just make sure that there's access to your community. I think in this day and age, we are trying to connect more with our original missions than we ever have in healthcare. At the end of the day, we are there to make sure that we can take care of those vulnerable folks. That is our mission. And the challenge is, it's gotten so expensive that we're really putting impacts on, especially Vermonters, working Vermonters and families and so forth. But I don't think we've lost sight of our mission in Vermont, that we need to look at costs, but we need to make sure we're taking care of those that are most vulnerable among us. And so I would look forward to working with the Advocate's Office on ways that we can continue to serve that patients of both our interests.
Thank you, Mike. Is there any member of the public who wishes to make a comment? Hamilton.
Yeah, this is sort of a
I'm sorry.
question and a comment.
I'm sorry, hold on. Can you say your name, please, and speak?
Hamilton Davis.
Okay.
I won't lie at all. My question is, I think that the cost per capita in the service area that Dr. Holmes is talking about is not age adjusted. It was calculated, but I suspect that it was not. If it is not, it is misleading. This kind of data was developed in Vermont by Jack Winberg in the 1970s, and it was available for at least 15 years. We can track every nickel as a cost per capita analysis along with others. And you can look exactly at it, so you can begin to compare. You can begin to compare one area, one hospital service area in Vermont to another. If you were to do that, then if you would have data that was level the playing field, then it would get to Kevin's question and Mr. Fort's reply about the orthopedic services. Kevin's obviously right that you're going to have it. In any fee-for-service thing, when you get an expensive procedure, you're going to have an incentive with fee-for-service to do more than you need. The only real defense against that, I mean, you can just trust him, okay? But if you don't want to do that, Kevin's a good guy, and he's one of your guys, but I'm not sure he trusts everybody. The reality is that if the Rutland Hospital orthopods were pushing too high volume just for non-justifiable reasons, okay, then that would have to show up in the cost per capita in the service area. And that's incredibly important to do that. The Winberg data was incredibly important. I spent a year on it in Vermont. I could see where every nickel moved. I spent 3 years at states from one end of the country to the other, Maine, Massachusetts, Iowa, Oregon, Washington, looking at the same kind of data, okay? And it's enormously valuable, but it has to be done right. And it's not fair to say, look, if the Rutland, according to Winberg, and I know this because I argued with him about it for hours, that the most important question, trying to level the playing field, is to look at age. Okay? If Rutland County age is significantly greater than the age in Chittenden County, then unless you adjust for that, you've got apples and oranges. Okay? I argue with Winberg myself that you should also put in an income component. People who are rich, okay, have a lot of money, they can really just slog the money all over their health, okay? If they're not wealthy, they can't. Now, Winberg disagreed with that, but I just still think he was wrong. I think if you have that data, cost per capita in the service area, then that's the best control you have on what Jim Daly used to call bow wow utilization.
Thanks, Ken.
And if I could just respond to that, I agree completely. And I think maybe you heard Jeff and Judy and I today talk about one of the infrastructure things that we need and we're working hard to put in place is data analytics. So we can have a chance to better. We spent the past 10 years at much expense putting together electronic health information systems, and it's been very painful to make sure we now have a lot of data in there, but we're getting relatively very little out to help us ask those and answer those type of questions and study that. Help, at the end of the day, help clinicians improve the quality and decrease the cost of care. So that is something we're working on. I hope next year when we come before you, we can say we have a data analyst and we have, a little bit more factual answers to some of those big questions that you asked us.
Thank you. Are there other members of the public with any comments or questions? Seeing none?
Can I follow up for a second?
Sure.
I just want to say about to Ham's point, I do agree that the measures that the Green Mountain Care Group put out there were not risk adjusted. It's based on how the all-payer model is going to hold us accountable for, financial agreements that we've made with the federal government. But the blueprint community profiles are risk adjusted, and to the degree that OneCare is starting to pull together, I think risk adjusted differences in total cost of care, we should have more data analytics and hopefully be able to really, it sounds like you're already doing that, really trying to understand data analytics and get at some of these high cost users and trying to understand how you can reduce utilization or more better care or better care management. So I appreciate all that, and I do want to say it's true that chart that we put in the budget guidance was not risk adjusted, because that's actually how we're held accountable. So I'm just trying to understand that hospital service areas.
So thank you. It was a very good morning, and thank you for the presentation. We're going to adjourn till 12:45.